So what we prefer to say is something like mental health conditions and general health conditions or other health conditions. And as you know, when you switch your language, you start to think about things differently. But as both Dr. Nemiroff and Teitelbaum pointed out to us, we have clear understanding now that there are structural changes that happen in people's brains as a result of environmental exposure coupled with genetic vulnerability, no different than any other set of chronic conditions, and that the process of repair is oftentimes the process of either rechanging brain chemistry or through relearning. I love the way Charlie talked about that. Relearning, we actually sort of rewire things. When I was a kid, my mom told me, and most of the things my mom told me actually turned out to be correct, even though she didn't know why. Like, fish is good for you, right? That's why you should eat your fish. And that's the omega-3 story. She said, take care of your brain because these are the only brain cells you're ever going to get, right? And most of us sort of believe that. And now we know that your brain does regenerate and that people have amazing recoveries after even pretty severe brain injuries. So there's a clear biological substrate here. That doesn't mean it's genetically determined completely, as Charlie said, but there are real structural changes, no different than structural changes in other chronic diseases, that they're rare conditions. We know that, in fact, these are among the most prevalent conditions, and I'm going to argue later on that because of the early age of onset, relatively high prevalence rates, and you've seen those, and the fact that we are terrible at early identification and treatment, these are, in fact, the most chronic illnesses, the most disabling illnesses in the United States. So they're not rare at all. In fact, according to that same global burden of disease study that Scott talked about, if you look only at the United States, Charlie showed the unipolar depression was going to go to number 2. If you look only in the United States, the mental illnesses and addictive disorders combined contribute about 33% of all disability related to illness, as contrasted with cardiovascular disease, which is about 16%. So these are the most disabling conditions because they occur young. We don't recognize them well. We don't treat them rapidly. And so we're constantly playing catch up. So they're not at all rare, and that they cannot be treated effectively. And clearly, we know that that's not the case. And we'll present some data on that. But both Scott and Charlie really highlighted for us the fact that we have an armamentarium of treatments available to us, well understood scientifically. And again, part of our challenge is closing this gap between what we know works and what, in fact, are routinely available to people. And this historical pattern of discrimination that Charlie was talking about in terms of stigma has been a real problem with that. We passed some parity legislation. You may have heard about this in 2008. We're now trying to get final regulations on that and trying to work with states to implement it. And I'm sorry to say that Florida has not been in the vanguard here in terms of some of the things that have been going on, particularly by your Blue Cross Blue Shield plans. So the science on mental illness and addictions. So mental illnesses are physical functions. Mental illnesses and addictions are reflected in physical changes. We've heard about that already. They disturb mental functions in the process transforming human experience. They are identifiable as signs, symptoms, and functional impairments. And diagnoses using specific criteria are as reliable in psychiatry as they are in any other field of medicine. Now, there's a lot of lability as somebody's getting ill, so their diagnoses may change as more data become available. But if your criteria for reliability is whether or not two people can independently reach the same judgment about what a person has, we're talking about reliably diagnosable conditions. The NIH with the NIMH, NIDA, the Drug Abuse, Alcoholism, and Mental Health Institutes, as well as the Institute of Medicine, which, as Charlie was talking about his wife's wild fantasies and his membership in that organization. That's a premier. That is the National Academy of Sciences, the ILM, is the premier scientific body in the United States, and they have all identified these themes about the reality of these conditions and their treatability and their burden of disease. Recently, they've done some really great work on prevention, highlighting again the fact that we have considerable, strong scientific basis for the effectiveness of preventive interventions that work exactly when Charlie was talking about the way they work throughout the lifespan, but they're particularly important for young children. It was great that he talked about that attachment. You know, we know the Visiting Nurse Partnership and other interventions work directly on maternal-child attachment. Those are not as routinely available as they should be. Research continues apace in terms of neurobiology and treatments. Charlie talked about genetic markers, and I like the way, we were hopeful that there would be major gene effects here, and we were lucky because we had just finished 5 major studies: the STAR-D study, the CATIE study, the STEP-BD, all of which had thousands of real patients in them. These are practical trials. And we had biological marker data on all data. You can tell I've been in the East too long. Data on all of these individuals. So we were certain that we were going to be able to start to do these genome-wide association studies and start to identify these major gene effects. And that has largely not been the case. And people argue, and I read just a good paper just the other day, that really if you look across health, there are very few indications that there are going to be these large genetic effects. The hope was that there would be, and then you could identify the proteins that were coded from those genes and develop strategies to impact those proteins. What we're seeing now is a much more nuanced picture where we have these genotype environment interactions. And so the news isn't as simple as we hoped it would be, but I think it makes a lot more sense in a way. And the good news is we actually have a lot of environmental interventions that will make a huge difference. Again, our challenge is getting those environmental interventions in place. This information will be familiar to everybody here, and it's just about the relative prevalence of these disorders. You can see anxiety and depression are the most highly prevalent disorders, and I thought Charlie did a great job putting a face on that. In talking about the fact that these are lethal conditions. Again, sometimes we don't think of them as being lethal. But as he said, that suicide rate is going up very predictably. One of the strongest effects of severe economic recessions are increases in suicide rates. It's about 1 person taking their life every 15 minutes in this country. So this afternoon you can calculate how many people will have taken their lives. These are lethal conditions. They're conditions that can be recognized, reliably diagnosed, and treated, and it's commensurate of us as advocates and professionals and people who give voice to these concerns that we demand that happens. Medicaid, I think as everybody knows, has emerged as a very important financing entity. And mental health conditions, again, they're conditions of adolescence, not well recognized, so people never reach that oftentimes, I'm overgeneralizing a bit, they have profound effects on people's occupational status. They're much more people with mental illness, they're much more likely therefore to be poor. They're more likely to be served by Medicaid either by reason of poverty or through the disability process and SSI. So Medicaid is hugely important. One thing that we have to watch out for as an advocacy and an interested community is as the Affordable Care Act moves forward and Medicaid expansion occurs, which is actually good news. Many, many people with addiction and mental health disorders are going to be in that 133% group, and we need to make sure that we maintain adequate benefit structure. You should be looking at what's being suggested in terms of the essential health benefits. The administration has basically kicked that back to the states rather than setting a federal platform. These are really, really important times. The availability of insurance and access to care is critically important. And what you see here in this slide is that the people who have both psychiatric disabilities account for a large amount of Medicaid spend. There's a whole new office on people who have dual eligibility between Medicaid and Medicare, and a large number, 52% of those, have a mental health condition. Something that Charlie hinted at but didn't say much about is the fact that the most likely comorbid illness with cardiac disease, diabetes, hypertension is depression and or anxiety, right? So if you have cardiac disease, if you have heart disease, your most likely co-occurring illness is depression. And if you have depression and cardiac disease or depression and diabetes, the expense for your care is about 2 to 3 times higher if that depression is untreated. and you also have much higher levels of mortality. So classic study, the impact study of depression and diabetes, indicated that in a 2-year period, and this is for older adults, a 2-year individuals who had diagnoses of depression and diabetes who were in the control group, who weren't effectively treated, had mortality rates twice as high in a 2-year period. Mortality rates twice as high as people who had their depression effectively treated. These are lethal conditions. They're expensive conditions. They're under-recognized, as Charlie was saying, undertreated. Same is true for the addictive disorders, but it's in our enlightened self-interest to control costs, improve the quality of care, do a better job of recognition and treatment. We know that these treatments work. Again, this is preaching to the choir. The success rates, and I thought that, you know, the stuff that Charlie pointed out about cancer, as I was thinking about this today, you know, when you have cancer, you don't say that you are cured typically, right? You hope that you're cured, but what you typically say is, I've been 3 years cancer-free, or I've been 5 years cancer-free, or hopefully, you know, 10, 15 years cancer-free. So you're in remission. Diabetes, and in mental health, in some sense, we need to think, I think, about things the same way. It doesn't mean you won't be cured. You'll never have another problem if you have an episode, for example, of depression or an addictive disorder. But it's important to think about the fact that these illnesses are of the same general class as these other chronic illnesses, and so our expectations about what works and what working means needs to be similar. And I really liked his point about remission. A lot of the studies we have focus on clinical improvement, and remission means that basically symptoms are gone. And his point is that should be our target. And here you can just see these are estimates of persons who improve with care, and you can see that the rates for the mental illnesses are comparable or better than the rates for other conditions. And I often talk about the fact that, you know, my nephew needed this MST, multisystemic therapy program, and in Colorado, you know, it costs about $8,000 a year a kid for that. And it's too expensive, too expensive. We can't afford that, you know. But what does it cost to put in a cardiac stent? I bet it costs more than $8,000. You know, that would to get in the door of the hospital would be $8,000, and we don't think a thing about. But no one would question putting a stent in for somebody who has cardiac disease. But for an MST program that could actually change the trajectory of a young person's life, in some sense, we devalue the importance of our own services. So this is kind of a list of mental health services that have been shown to be effective, and you can see that the list is substantial. Emergency room diversion has to do with alternatives for individuals so that they don't end up in emergency care. And you can see that ER visits, we'll see later by some other data, reflect in some sense, the ER visits and police encounters and incarceration really reflect the breakdown of our inadequate treatment systems. I remember when we were doing the Florida Commission, one of the sheriffs, I think, who was attending says, you know, the day when you call 911 and 911 says, geez, I'm sorry, we're full. We've done all our 911 calls for today. Could you come back tomorrow? Will be the day that things will fundamentally change, right? But and again, I've been out of Florida for almost 6 years, so I've lost touch with what's going on here. But you know, it used to be routinely emergency rooms would be full, and people would be discharged prematurely, or they would waive the police by, and so ultimately, as we know, the all too common story of people then entering into the criminal justice system. And Steve Leifman's here, and you may want to talk about that a little bit later. You can see that we've lost a lot of inpatient beds in Florida, and that this idea of having alternatives for people so that they don't go into crisis obviously makes sense. And what we have below is the number of persons who received emergency room diversion services, and we're thinking, John and I worked on these numbers a little bit, and we're thinking this relates to mobile crisis services and not others. And so you can see kind of the average unit cost for the delivery of that. Assertive community treatment, you know, something that was shown to be cost effective in 1978. And the actual research, I think, was done in 1975, has been shown to reduce ER use and hospital use, et cetera, et cetera. The only thing that makes me happier about that is my friend Bob Drake was giving a presentation, and he talked about scurvy and the classic study that was done by the British Navy when they had 3 ships crossing the ocean, and they had all this problem with sailors getting sick on the ship. So on one of them, they put all the citrus fruit on, and the people who had the citrus fruit, vitamin C, we know, causes people not to become ill with scurvy. And it was like a natural experiment. Very strong results. No scurvy on one ship, lots of scurvy on the other 2 ships. And how long do you think it took them to get that routinely to have citrus fruit available on ships? According to Bob, it's about 180 years. So even though ACT was 1978, and we need to expect to move our science into action much more rapidly, we at least have moved forward from the 17th century. Acute care and crisis stabilization. We talked about mobile crisis services in terms of effectively diverting people from hospitalization, but not arrest, interestingly, and linking people to ongoing ambulatory or outpatient care. There's mixed evidence, evidently, about crisis residential services in terms of their effectiveness, and Gail says we really need a real meta-analysis done here. No notable improvements related to symptoms and psychosocial functioning. Patients like the residential services, that they reduced cost compared to hospital care and reduced hospitalization days. 23-hour crisis stabilization has limited reliable research, but does show a decrease in hospitalization rates, which is good, because that's a direct substitute for hospitalization. And there's limited cost comparison data that shows crisis stabilization units are cost-effective alternatives to inpatient hospitalization for some patients. There are still areas where we need more information. Charlie talked a lot, and Scott talked a little bit about psychopharm, but we know that psychotropic medications alter brain chemistry and oftentimes are very helpful in terms of symptomatology. And the data seems to indicate that they're best combined with other services and supports, and long-term or even lifelong adherence may be necessary. So again, it's like other chronic conditions. There are multiple strategies that are available. The psychopharm clearly is an important one, particularly in our country, and it needs to be continued as, because again, in the essential health benefits, the requirement from the Department of Health and Human Services is that only one drug be available in each major drug class. So that means that a formulary would only have to have generic Prozac, for example, and not the 14 other antidepressant medications that Charlie was talking about. We have very good data from the STAR-D study and from Katie that the reactions to these psychopharms are very idiosyncratic, and that it's really important that we have all the tools in our tool chest. So that's why it's important to continue to monitor what's happening in terms of the implementation of the Affordable Care Act. We have some data here about the number of adults, about 8%, 330,000 out of the almost 4 million adults in households below 200% of the poverty level in Florida need publicly funded mental health services. Of these, about 24% are uninsured. That's higher than the national average. This relates to this point about what's going to happen in part when we go to 133% of the poverty level. Only about 19% of the people who were uninsured became eligible for Medicaid, and you can see here the appropriation that we have for the indigent drug program is inadequate relative to the number of people who need access to pharmacological treatment. This is data from the Katie study. Remember, that's the large practical trial of people with schizophrenia that took a look at the atypical agents against perfenazine, the second drug here, which is a typical antipsychotic agent, and found that in terms of symptom reductions, there was no large difference between these drugs. But I think that the major point of Katie was that the vast majority of people failed off the drug that they were initially randomly assigned to, except for those people who were randomly assigned to the drug that they were already taking and that was working for them. And what this says to me is not that we should preferentially use perfenazine, a first-generation drug, although it should certainly be considered depending upon how patients react to it, but that it's critically important that we have access to multiple pharmacological agents to help people with severe mental illness so they can find that particular drug which works best for them. This is data from the, and that I think Charlie talked about, this is from the STAR-D study, which is the big practical trial for people who have depression. And the good news from that trial is that about 70% of the people treated in the STAR-D trial ultimately did remit, but only about 30% or 35% remitted with the first treatment. And to get to 70%, they had to use 4 different approaches for people who weren't improving at the rate possible. So again, this underscores the fact that we have effective tools, but that these tools work differently for different people. And it's really important that we have a full armamentarium of approaches available for us in terms of dealing with this. And this has direct relevance for pharmacy and for the formulary. Bipolar disorder, adding an antidepressant to a mood stabilizing regimen is no more effective than taking a placebo. Careful management of a mood stabilizer medication is a reasonable alternative to adding an antidepressant medication. And patients taking bipolar medications seem to get and stay well faster if they receive intensive psychotherapy in addition to taking medication. And I hope when we have the discussion section and Charlie returns that we'll be able to talk a little bit, maybe if people have questions about bipolar illness, because it's funny, it's kind of the poor stepchild in a way of the research that's gone on in mental health. I remember when I was reviewing for NIMH, one of the grants for a center in bipolar illness pointed out that it was one of the least well kind of understood disorders, certainly relative to schizophrenia and depression on the mental health side. Here is something that I think someone in the audience offered before to a rhetorical question that Charlie posed to the audience, and that's that medication and psychotherapy work well together. CBT, cognitive behavioral therapy, I love his metaphor about top-down versus bottom-up, but that by changing cognitions, by changing the way we talk about things and think about them, we actually learn to react differently to our own emotions, and we now have lots of data on the effectiveness of CBT. We have various even kinds of, Steve Leifman and I were at a group last week talking about some of the computer-based CBT interventions that are being developed that some people will find very helpful. And in some sense, we suffer from what I call the Woody Allen syndrome. And that's still, when people think about psychotherapy, they think about Woody Allen and psychoanalysis rather than these very structured, so they think about it as sort of this neurotic guy who wants to get self-improvement and could go on in therapy for years and years and years, as opposed to these, very systematically implemented, well understood interventions. Now, we got, I think it's fair to say, a lot of work actually getting competent CBT to be delivered everywhere, and that's like every other area of medicine. We have a quality control problem in mental health, just like in all other areas of medicine. But when it's delivered effectively, it works, and it works as well as other chronic disease management programs do. Gail says that there's inconclusive information about family psychosocial education. It increases the compliance, the notion being hopefully that through a psychoeducation program we can really start to understand people's needs and desires. There's strong evidence that adult family psychoeducation brings probable outcomes. And I remember Bill McFarland's work from a long time ago about multi-family group psychoeducation. It had dramatic effects in terms of reducing hospitalization. Whoops, I can't. And at the bottom, I'm cutting some sort of short shrift, and you guys have all these slides, and you have Gail's paper, which also has not only this information in it, but it has the documentation about how these numbers were calculated, which I think you'll find helpful. So you see psychotherapy and psychoeducation services, non-medication based, and these are state general revenue dollar amounts, right? So if you look for adult mental health, about 61,000 people receive those services, and the GR side of that's about $72 million, which turns out to be about $1,200 per person. But if we added Medicaid funding into this, it would look substantially different, because we know that some of these GR funds are used to match Medicaid funds, and we also know that there are Medicaid programs which bring their own GR revenue to the table. So this underestimates the state's expenditures, I think it's fair to say, John, on these conditions, but gives you a sense about what our general revenue budgets are in Florida. We talked about assertive community treatment. We've known about it for a long time. There are variations of it now that include peers, which offer some very promising results. And and it's very interesting, because this was, in fact, a study done in the 70s by Marianne Test and Len Stein, along with Bert Weisbrod, an economist, which is kind of a rare combination. Not so rare now, but back then it was rare to have an economist working with you. And not only did they show that the outcomes they got were superior to the outcomes of people going into Mendota State Hospital, but it actually cost less in the aggregate. So they actually had a cost effectiveness, which is very unusual. And as I said, we had the FACT program here. Many states have assertive community treatment programs available, but the dissemination of those has been slower, I think, than it should have been, given what we know about their effectiveness. And interestingly, Gail concludes that there's no strong evidence with regard to their effectiveness in working with people who also have substance use conditions. Here's some data on case management in Florida, and this is both ACT as well as ordinary case management. And so you can see that, the 67,000 people served for $63 million, or about $950 a person. But again, that's a GR, but it gives you a sense comparatively across these different sort of service types.
David,
yes?
Excuse me, those dollar figures there also include first and third party fees and local match.
Oh, okay.
That were expenditures for persons receiving those types of services.
Oh, okay, good.
So it's primarily GR, but it also includes some other fund sources.
Terrific. So John said that in private pay, right, plus other county match would be included in that as well. Thanks, John. We have several supportive interventions, which we know to be effective and are not as universally available as they should be. Supported housing, and this is essentially placing people, excuse that language, helping people obtain housing of their choice in normal community housing, so not segregated community housing, and then providing variable levels of support to those people in that setting. And we have a lot of data to indicate that improves housing outcomes. Pathways to Housing is a program in New York, which the Housing First program uses a supported housing model, and it's been around. I'm going to be such an old guy. I can remember when Paul Carling came to Colorado, probably about the same time that Bert Weisbrod was doing the study, and started to talk about it. It doesn't make sense when someone gets better, you force them to move, right? We used to have this hospital three-quarter way, halfway, quarter way, and then bye, rather than variable supports to people where they live, depending upon what they need. And again, we have a lot of good data that indicates that this works, and you can see that only about 5,000 adults receive that, and only about 1,200 kids receive supported housing interventions, and that they're relatively more expensive, but again, it depends what you're comparing them to, right? So if you compare that to someone ending up in long-term hospital care or in jail, these are very cost-effective interventions. We have enormous information about supported employment. I mentioned Bob Drake. He and his colleague Gary Bond summarized the data, I think, from about 18 clinical trials testing supported employment against other kinds of supported, other kinds of interventions, and clearly indicating in every trial the differential effectiveness of supported employment. You can get competitive employment rates at about 61% versus 23%. If you look at people with severe mental illnesses, 23% actually typically would be a pretty high number for people who are in competitive employment in our systems, in our state systems, and they can get those rates up to 61%. Pretty reliably. Bob has done a multi-state study that was funded by the Johnson & Johnson Foundation and formed a learning community and has now implemented these programs around the United States with fidelity. But again, despite its success, further evidence is needed in terms of long-term job retention. That does get to be an issue, and part of it is the way we sort of factor dependency into our welfare programs. We sort of it makes it very difficult for people. Hopefully more universally available insurance will help with that, but we've designed programs that really capture people in them, and it's difficult to get at, and also the employment situation in general hasn't been very good. Mental health courts, research literature is limited in terms of number and scope. Some have lower rates of recidivism and decrease the likelihood of arrests for new crimes. They're more effective at connecting individuals with care, and I haven't looked into the mental health court literature in a while, but that was kind of this part of this therapeutic jurisprudence movement to really start to use those levers to get people access to care. They can potentially save money through reduced recidivism and the associated jail and court costs that are avoided, and also through decreased use of most expensive treatment options. So it's really hooking people up with an adequate community support service. So again, you can see a theme kind of emerging here, right? It's finding people, helping them to achieve their goals. That's what the supported housing, supported employment are about, providing variable levels of support for them to reach their goals. Mental health courts, in part, are about getting people out of a punitive system and into a rehabilitative system. And ultimately, of course, it would be great if we could start to use some of the resources that are saved, and Steve can talk about this as well, from getting people out of jail into an effective treatment system. So again, there always are issues with implementation, but our science base is pretty strong, and I think we know what to do. We can always use more research about the basic biology of these problems, and that makes our case more compelling. But our interventions are typically, number one, we're dealing with issues of motivation, we're dealing with frustrated access, but the science base is actually quite strong. Integration of primary and behavioral health care, this is critically important, because remember what Charlie told you about most people with depression, for example, which, we talked about the burden of disease associated with that, are not seen by mental health professionals. They're seen in primary care. And because of exactly what Charlie was saying, their problems are under-recognized. We're doing a lot better than we have in the past. They're still under-recognized and under-treated. And when they're under-recognized and under-treated, they cost a lot more money, and the outcomes we get are a lot poorer. We have a very well-understood model called collaborative care. I think there have now been over 24 randomized trials. I have a meta-analysis. If anyone's interested, I can give you the reference, that looked at the outcomes of about 12,000 people who were treated in these trials. And it's very clear. Collaborative care is placing behaviorists right in primary care settings, so there's no need for a referral. The behaviorist is there. They provide the support that the person needs around their behavioral health issues. It has dramatic effects in terms of the person's depression over a 5-year follow-up period. We're still getting significant effects over a 5-year follow-up period. And more recently, the group at the University of Washington who's been working on this has shown that it costs more money in the first year to provide collaborative care, but in fact in the second year and on, it's a money saver, that the persons who receive the collaborative care, their utilization drops. Part of our problem in finding this cost offset effect, they would argue, is that we typically have only looked for a year. One of our big problems is our outcome studies. Many drug trial studies are only like 6, 8, 12 weeks, 6 months. And we know that these disorders play out over years. And when the people who did the impact study looked in year 2, they found the cost offset, and in year 3, and in year 4. You're going to hear a lot more about collaborative care, I hope, because Jürgen Unser, who's one of the sort of champions of this at the University of Washington, is hell-bent on implementation. And I say more power to Jürgen. These are 3 evidence-based treatments for kids. There are a bunch more. My colleague Kimberly Hoagwood, who used to be at Columbia University, has now moved down downtown to New York University, has a really nice paper, I believe. I know she has some really nice tables that I've used before that goes through all of the evidence-based treatments for kids, and there are a bunch. These are the three best known: functional family therapy, therapeutic foster care, and family-centered behavioral management, that have been shown to be effective. So just like on the adult side, on the kids side, there's an armamentarium of studies. The multisystemic therapy that I mentioned to you earlier, I think that there have been 20-some randomized trials of that on kids. Remember, that came out of trying to develop interventions for kids who were headed into JJ, right, juvenile justice. And as you know, if you go into JJ, it dramatically increases the likelihood you're going to enter the adult criminal justice system. It just makes no sense, ladies and gentlemen. And we have ample evidence about MST, for example, as an alternative for acting out kids. And if anyone's interested, just come up and I'll find. I sent Kimberly a note this morning to ask if she had published that, and if not, I can certainly get you the tables and other things. Now, we have some data from the National Center on Drug Abuse, and what you'll see is that for the addictions, the story is basically the same. There are an armamentarium of treatments that are known to be effective. So there are multiple medications that can be useful in helping treat drug addiction. You know, buprenorphine is the one that we're hearing, at least I'm hearing most about. Methadone has been around for a long time. Naltrexone, I don't know what LAM is. I'm sure that stands for lipoaminic acrylic methylene or something. I don't know. And the other, and so there are, and nicotine replacement, you know, gums, patches, and buprenorphine have been helpful. And it's really important, I think. It's funny, I was on a call the other day and we were talking about chronic illnesses. And I can't remember the exact context, but it seemed as though the addictive disorders, the way they were framing it, that people with severe mental illnesses would not be part of this particular study. This is an NIMH call or something. And I said, well, you know, why would that be the case? And he said, well, just think, and it turns out that they would be, the people with severe mental illness would be, because they're very likely to be addicted to nicotine, right? 44% of all cigarettes smoked, this is the National Comorbidity Study, everybody know this? 44% of all cigarettes smoked in the United States are smoked by people with mental illnesses and addiction disorders. And it causes, Scott didn't talk about it, but that nicotine is, that Nora Volkow has these very powerful slides that shows how nicotine potentiates the receptivity to other drugs of abuse, so we need to think about it. And fortunately, we have nicotine replacement and other therapies that work. Issues about motivation to enter and sustain treatment. This is a critically important area for both the addictions and for people with other kinds of mental disorders. You know, the motivational interviewing, moving people into action. As any of us who try to change any behavior know that it's hard, number one, and number two, that sort of developing a sense of the possibility, right? Going from pre-contemplation to contemplation, moving along that continuum requires help and support, and so motivation is critically important, really for all of them, but definitely so in the addictions. I was very curious to see that the information that Scott presented, where he showed the excitatory areas of the brain when a person who had an addiction and how that sort of works on the compulsivity or impulsivity to use those disorders. So sanctions and enticements can increase treatment entry and retention. You know, drug courts were around long before mental health courts, and I think worked on some of those same issues. And the treatment outcomes are similar for those who enter treatment under legal pressure versus those individuals who enter it voluntarily. So it's interesting. We have an interesting discussion probably about the similarities and differences between addictive disorders and other mental health types of conditions, and the use or misuse of coercion in those. I know that's an area on which we continue, although our advocacy organizations are working better together today, I think, than they ever have in my 30-year history working in this field, that some of the areas around coercion are still areas that divide us. HIV, AIDS, hepatitis, and other infectious diseases, that drug treatment is disease prevention, right? And it's preventing infectious diseases, you know, particularly HIV, and hepatitis. It reduces the likelihood of HIV infection by 6-fold for injection drug users, and drug treatment presents opportunities for screening, counseling, and referral for individuals who are at higher risk. So it's both a portal in for people who have become infected, and also effective drug treatment actually drives down the rates of those infections. So the goal of treatment is to return people to productive functioning. Again, I really like the definition that Scott had of recovery. And that's just sort of a general summary, and it looks pretty similar, doesn't it, to what we saw in terms of the mental health treatment. So treatment reduces drug use by 40%, crime by 40 to 60%, increases employment prospects by 40%, and drug treatment is as successful as treatment for diabetes, asthma, and hypertension. So again, we have nothing to be ashamed of. And I love Scott's response to Mark's question, about the, don't let facts get in the way of your opinion. Because I think we have a formidable factual base on which to argue that not only is it the right thing to do, not only is it the equitable thing to do, it's the smart thing to do, and we're not going to, I think you can make a compelling argument that we're not going to start to address some of the fundamental problems in our society until we get much more assertive in terms of behavioral health treatment and prevention. And then finally, we were talking about 12-step programs, self-help and drug addiction treatment that complements and extends treatment efforts. Most commonly used models include AA and NA, smart recovery, and most treatment programs encourage self-help participation during and after treatment. The nicotine replacement works best if you're part of a support group that's helping people to not smoke while they chew their Nicorette gum. In fact, I think, I'm not 100% familiar, but I think that those are the only trials that have been shown to actually be effective with nicotine replacement gum. I could be wrong. So support of individuals who are working with any of these problems is critically important. Oops. And finally, there's good cost-effectiveness data for drug treatment. So it's less expensive than not treating or incarceration. And here they talk about one-year methadone maintenance costs about $5,000 versus $18,400 for imprisonment, which sounds low to me. But I thought it was more around $30,000 to keep somebody in prison. No, it's like 18, huh? Yeah, okay. What's what? In Florida, it's about 18,000. Okay. Every dollar invested in treatment yields about $7 in reduced crime-related costs. Savings can exceed costs by 12 to 1 when healthcare costs are included. So reduced interpersonal conflicts, improved workplace productivity, and fewer drug-related accidents. And we could talk about the same. We didn't talk at all today about productivity on the mental health side. Depression and anxiety disorders are huge problems with regard to presenteeism. And this, again, has been very well documented. It's literally in all of our enlightened self-interest to do a better job with regard to these issues. But this is cost data, and in fact, there's an error in this slide. These are very expensive conditions. I was telling John that the best study, I think, was done by Kessler. I don't know if you noticed, but that many of the slides talk about Ron Kessler's National Comorbidity Replication Study. And he did the best study of lost productivity. And Ron estimated, using his definition of serious mental illness, that each year, in 2002 dollars, we lost $193 billion in human productivity because of severe mental illness. And that sounds like a lot of money. If that money turned up in your checking account, I guarantee you would notice it. But when you're talking about a $3 trillion, you know what I mean, with the numbers we talk about now are so astounding that we've kind of become numb to that. It turns out in 2002, when Kessler did the study, only one company in the United States had gross revenues greater than $193 billion, and that was Walmart at $202 billion. So we're losing from serious mental illness alone, which has obviously substance use associated with it, and so none of these things are clear. But from SMI alone, we're losing the equivalent of a Fortune 10 company each year. And I trended that forward, and I think currently ExxonMobil and Walmart would be number 1 and number 2, but serious mental illness would be number 3. The very, very expensive conditions. And a large part of that is the indirect costs. And again, these figures are in here, and I know that I'm getting close to my time, and after I harangued everyone else, I certainly shouldn't go over, right, Mark? That would not be cool. This just goes through, essentially, talks about the prevalence again, and just about the impact. And again, you guys have all of these slides, which you can use in your talking points tomorrow. Individuals with mental illness in Florida jails and prisons outnumber those in state mental hospitals by nearly 5 to 1. The Miami-Dade County Jail holds 5 times the number of persons with mental illnesses than any psychiatric hospital. And of course, that's true nationally. Think about 2 million people in prison, and various rates estimated for serious mental illnesses. I think the one Stedman uses is 7%. It's 140,000 people. That's 3 times more than we have in state hospitals. I've seen justice figures that at 16%, it'd be 320,000 people in prison. That doesn't count jails. That's just prisons, which is 8 times the number of people we have in state hospitals. So we have a great challenge in terms of the institutionalization of those hospitals. And what I want to do, so this, the return on investment slides here, and you'll see as you look through them, are less on ROI in some sense than they are on the distribution of costs. And this is something, again, that we've known for a long, long time, that a very small number of people, in this example, about 1.2% of the people who are served in the mental health system consume about 28 to 30% of the overall resources. And many of the assertive community treatment and intensive case management type programs, really their bread and butter is trying to identify people who are having such a hard time and working with them to find a solution that works for them. So every healthcare expense distribution you look at is going to look like this. There's going to be a small group of people who are really having a difficult time, and our goal is to among other things, is to better identify who those people are and provide them those kind of support services that we know work, and ultimately that will end up smoothing that cost curve out a bit. And we have the same data for children. And again, here you have, 4/10 because of the use of residential treatment would be my guess, using about 17% of the overall resources. So it's a very asymmetric distribution. How am I doing, Mark? Huh? My time is up? So we don't want to do the recommendations then, right? Her recommendations essentially are that we really should start to do rigorous analyses to demonstrate the potential impact and savings of behavioral health programs that are already in place in Florida. And she presents in the paper, and you all are familiar, I think, with this, with the outcome data that are available, which I think look very good. I mean, the programs are working, even under these extraordinarily difficult fiscal circumstances that we're operating under. That building on the initial work in Gail's document, additional analysis should be conducted of the high utilizers and low utilizers, and both in the adult and children mental health. So who are those people, and what could we do to better serve them? And more in-depth analysis may indicate opportunities to reduce the use of residential services for youth and or develop broader array of services for adults. The conclusion is that increasing information sharing for advocacy and quality assurance purposes would help make the case for mental health services in Florida. So that calls for essentially mining our own data more aggressively. This gives you some information of the rates at which people improve who are treated. And I think we're doing well there. I was here when that outcomes system was being implemented, and that was wasn't as bad as renaming our organization from National Mental Health Association to Mental Health America, but it was a pretty painful time. The recommendation 3 is, since there's sufficient evidence of the efficacy of behavioral health treatments on quality of life, health and human service costs, productivity gains, expanded lifespan, and because of Florida's current per capita spending rank, at a minimum, funding should be maintained, and hopefully new short and long-term funding increases will reduce other system costs. So that's just the thing, that this again just makes the argument that not only is it the right thing to do, it's a smart thing to do. Given the databases that are available, data analysis should be conducted and used more often for advocacy and quality management. So I think that Gail's conclusion was that we've got data, we're not perhaps featuring it as powerfully as we could in terms of the advocacy organizations. The conclusion is focusing more on streamlining services and systems for quality improvement and efficiency may result in further savings and efficiencies. And then finally, the final 2 recommendations are using existing data supported by more in-depth assessments, may be possible to identify a number of both adults and children who could be involved in a demonstration program. So here Gail is saying that it might be, given that the constrained fiscal environment, it might be best to try to do a demonstration or a pilot and demonstrate that these evidence-based practices with the proper support will work in the state. And building on this recommendation, state policymakers, administrators, advocates, consumers, and families should consider collaborating to develop a plan to increase the number and span of evidence-based behavioral health, rehabilitation, recovery-based services in Florida. And you thought those New Yorkers to talk to us. You're welcome.
Very much.
I'm Mark Fontaine, Florida Alcohol and Drug Abuse Association. I want to thank each and every one of you for coming. You know, and he was throwing around numbers like trillions, and I tell you, the numbers that strike me are the numbers we're talking about. Is a $26 million cut to substance abuse that's being proposed, and a $53 million cut to mental health now. Those are huge numbers. Those are not little numbers. All this data shows that what we're doing works. So to put that many thousands of people on the streets is what we need to make sure it does not happen. So I'm going to use what Charlie says. Choose your words. It's not going to happen. We're going to win this battle, and we thank you all for participating in this today. We invite you all tomorrow to the behavioral health rally that'll be held in the courtyard between the old and the new Capitol. That rally assembles at 10:45, and at 10 o'clock at Park and Adams there'll be a behavioral health walk to the rally. So if you want to participate in that, NAMI is hosting that. That's at 10:45. Please do, and please be in the courtyard tomorrow of the Capitol at 10:45 so your voice can be heard about what needs to happen to keep these services and keep the people that we're serving in care. And I want to thank you all very, very much for coming today. We appreciate it.